Yes. Hi there, Karishma. Good evening. Yeah. Okay. Are you able to hear me?
Am I audible, sir?
Yeah. Loud and clear. Perfect. So how are you?
Going good, sir.
Everything going good?
Yes,
All right.
yes.
Good. Let me just spotlight your video for everyone. Okay. Yes. So good evening, everyone. I think we also have our colleagues from IDA Davangere branch as well. Good evening, Dr. Soumya. Soumya ma'am is here. Also, Sangeet ma'am is also here. Hello, ma'am. Hi, ma'am. Nice to see you. Okay, good. Good evening. Sangeet ma'am is also there. Let me just put across Sangeet ma'am. And we also have our students joining in. Okay. So good evening, everyone who've joined us in on the Wisdom Wednesdays, as we like to call it, the PhD 101 Rapid Revision series. Is my audio and video clear, Karishma? There?
Yes, sir. Yes, sir.
Perfect. All right. So the whole purpose of having these is in the times of examinations, which are about the corner for most universities. Our very own Rajiv Gandhi University exams are starting in the month of October. So we've decided to take up exam-oriented topics and give like a quick rapid revision on commonly frequently asked questions for the undergraduate level. Also adding an emphasis on the utility for the postgraduates of not just public health dentistry, also the other departments like pedo and perio and most of the other topics which are overlapping. So in that direction, I welcome all of you to yet another session of PhD 101 National Level Rapid Revision Series. Again, it gives me immense pleasure to announce that today's session is brought to you in collaboration with the Indian Dental Association, Davangere branch. So my heartfelt gratitude to everybody at the IDA Davangere branch, from the Dr. Neeta ma'am, who's the president of IDA Davangere, Dr. Pramod sir, the secretary, honorable secretary, and also Dr. Soumya ma'am, who's also the CD in charge for IDA Davangere. Thank you so much, everybody at IDA, for extending the support to us in making this happen. So without taking much of your time, I'd just like to introduce speaker for today and also formally invite Dr. Soumya ma'am to invite everybody to the panel. Dr. Karishma Halageri, who's just completed her master's in dental surgery in the field of public health dentistry, someone who I know very well from her undergraduate days at College of Dental Sciences, Davangere, and also after completing her post-graduation from Rajarajeshwari Dental College and Hospital, Bangalore. She's someone who holds community work very close to her heart and someone who's taken up the specialty, and very peculiarly the way she's dealing, and she's had very amazing presentations at various of our conferences. So I've had the pleasure of knowing her personally and also her expertise in the field. Someone who's just completed and completed her post-graduation. She's full of knowledge and a lot of updates. So I'm really sure that she'll be able to do justice to the topic today, which is caries risk management. So we're going to talk about the various techniques and tools in that. So now I'd like to request Dr. Soumya ma'am, the CD in charge chairman for IDA Davangere, to just give us an invitation formal from the IDA Davangere branch. Yes, Soumya ma'am. Yeah, please go
Good evening, everyone. Good evening, all. So I welcome Dr. Karishma.
Thank you, ma'am. Thank you so much.
So she'll be talking or enlightening us with advances in the caries detection techniques and various detection tools and its significance, which is important or it is key for both the general practitioners as well as for the budding dentist. So over to you.
Thank you, ma'am.
Thank you so much, ma'am. Thank you. Okay, so I think we are good to start the session. There are participants joining us in from across the country. As I can just have a look at the participants here, we have Dr. Padma K. Bhatt, ma'am. Nice to have you, ma'am. Good evening, Padma, ma'am. Yes, again, an eminent senior faculty member from our specialty. Then we also have a couple of postgraduates who's joined us. Hello, Padma, ma'am. I think I can just say hello. Hi, ma'am. So nice to see you. Okay, so I'm going to wave out. So I think we have people from Karishma's college as well. So good to see everybody here. All right. So, like I said, this topic we've chosen because Kiri's risk assessment techniques and tools are becoming very, imperative in day-to-day practice. Even when you talk about chair-side experience, when we need to convince patients, and a lot of education and motivational techniques are built around these fundamental concepts. And as we fight the burden of dental caries across the world, and especially when we see the inequalities and the distribution of disease per se, there have been recent advances which I think will be really helpful for students, for practitioners, and for teachers to keep themselves up to date in this arena. So in that direction, I'd again like to just request Dr. Karishma to please take over the proceedings for today. Yeah.
Yes, sir.
Yes, Karishma, you can share your slide, please.
Yes, sir.
Yeah, please go ahead, Karishma.
Yes, sir. So good evening, everyone, and thank you for all the faculty members for joining in and for all the participants as well. Before starting the session, I want to thank for the opportunity for Dr. Denzi Lawrence sir and for PhD 101, and also the IDA Davangere branch for collaborating for this webinar. And it's an honor to present in the esteemed faculty members in front of. And I would always show my gratitude to my guru, Dr. Padma Kebat, and my guide, Dr. Aruna ma'am. So these are the contents I'll be talking about. First, the introduction on caries risk assessment, goals, terminologies, and for certain criteria such as caries disease indicators, risk factors, protective factors, and caries imbalance model, techniques, tools used, and the tests used in CRA, and accuracy, uses, and clinical applications of CRA, and conclusion and summary. As Denzi sir said, it's not only an important topic in public health dentistry, but also in the general practice, which makes us able to do in the clinical decision making. So, at the end of the session, participants will be able to understand specific risk factors, protective factors, and disease indicators of dental caries, accurately quantitate a person's disease susceptibility and allow for preventive measures, and they can briefly know, compare, and contrast the different methods and tools. And also, they can guide the choice of CRA method that will support caries management decisions. And also understand the disease factors for a specific patient and aid in individualized preventive discussions. Coming to the introduction, before going in depth with the CRA, we should know why there is so much focus on caries risk assessment. We all know that dental caries is widespread irrespective of the geographical locations and food culture and socioeconomic status. The disease burden remains a global public health burden, with statistics indicating approximately 44% of all the people worldwide suffering from untreated caries in both primary or permanent teeth. So we have certain different modalities, treatment modalities in dental caries, even in the restorative care and also in the preventive sector. Even though the dental caries is a major issue of concern, so we need a caries risk assessment in determination of likelihood of incidence of caries during certain period, or change in the size of active caries which is already present. So nowadays, the most oral health professionals seem to perform an informal and intuitive caries risk assessment, such as just by taking case histories or examining their patients. This is a T diagram showing the factors influencing the initiation, transmission, and inhibition of the dental caries. From this, we know there is not only a single factor that is causing the dental caries. There is numerous primary modifying factors and secondary modifying factors. So we should know which is at risk, which is causing the dental caries. It might be causative or modifying. Several scientific investigations has set the predictors for risk of caries, which might be the clinical signs of caries, or risk indicators, which is the causative or modifying. So the causative relationship are often identified as caries risk factors. So we need a specific tool to assess the overall risk factors of an individual. So there is no single test that takes into consideration all factors and can accurately predict individual susceptible to caries, like which risk factor is causing the dental caries. So the caries risk can be evaluated by analyzing and integrating several causative factors which play an interplay with variety of social, biological, and behavioral factors. So it is established that high risk patients always have a high bacterial challenge. It might be Streptococcus mutans or lactobacilli or both of it. So although fluoride has an excellent properties in terms of balancing caries challenge, if the challenge is too high, then the fluoride, even at high concentration, can't decrease the caries susceptibility. That means there is always a balance between the pathological factors and protective factors. So before going in depth, let us know what is the meaning of the term risk. It's a probability that harmful or unwanted event will occur. In epidemiology, this is probability that the particular event will occur within a given period of time. So for this, risk assessment is a professional judgment of an individual future risk of disease based on the best information available. Based on the information available, we will do the judgment for the future risk of disease. Coming to the caries risk assessment per se, it is defined as the clinical process of establishing the probability of an individual patient to develop caries lesion over a certain period of time, or likelihood that there will be a change in size of the activity of lesions already present. In general, it is a procedure to predict future caries development before the clinical onset of disease occur. So we should know why we need caries risk assessment. First of all, dental caries is classified by WHO as plaque-mediated non-communicable disease with complex network of biological, genetic, behavior, and socioeconomic and lifestyle-related risk factors in common with other NCDs, for example, obesity and diabetes. So this assessment is linked ideally to appropriate care planning decisions on preventive and restorative care as well, and periodicity of future recall consultations also. So this CRA fosters the treatment of disease process instead of treating the outcome of the disease. And it also allows an understanding of disease factors for specific patient and aid in individualizing preventive decisions. And it individualizes, selects, and determines the frequency of preventive and restorative treatment for individual patient. And it also anticipates whether there is a caries progression or there is a caries stabilization. So this caries assessment, risk assessment contributes to determine needs and extent of personalized preventive measures. For each individual, there will be a specific preventive measure according to the risk factor present in that specific individual. And it also helps in the motivating the patient to know what risk factors are present in him. And it also helps in monitoring the effectiveness of the programs such as school toothbrush programs or pit and fissure sealant programs. And it also identifies high risk groups. And it is also needed for the determining the need of caries controlling measures. And it also aids in establishing recall protocol and patient or group selection. The goals of caries risk assessment include it screen out the low risk patient, and it identifies the high risk patient before they become caries active, and also it monitors the changes in disease status in which caries active patients are already there. So the aim of this is identify caries active individual and convert them into caries inactive status so that they become low risk for the disease. We need to understand some terminologies of CRA. Those are caries susceptibility. What is caries susceptibility? It is the resistance of a tooth or a susceptibility to a caries producing environment. That is, in a simple term, it's a risk of developing a lesion. However, in individual, it varies depending on the tooth, its location, its surface, and also the fluoride exposure. Coming to the caries activity, it's a measure of speed of progression of the caries lesion. Retrospectively, if we go, it gives the caries incidence and also new caries lesion over time of an individual or population. Then coming to the caries prediction. So prediction is clinical decision about the outcome of the disease process based on the information which we have. So susceptibility is risk of developing a lesion, and activity, caries activity is a speed of progression of a carious lesion, and prediction, it is clinical decision about the outcome of disease process. Coming to the major criteria used in CRA, those are caries disease indicators. What's the term in disease indicators? These are clinical signs that has a disease is present or that has been a recent disease. They simply describe a clinical observation that indicates the presence of disease. It is neither a pathological nor they are causative in any way. It's just a simple observation, physical observation, which we see in a patient. So some examples of disease indicators are frank cavitation or lesion that show radiographically show penetration into the dentin, or approximal radiographic lesion confined to the enamel only, or visual white spot on the smooth surface, or any restorations placed in the last 3 years is also a caries disease indicators. Coming to the caries risk factors, they are biological factors. They contribute to the level of risk for the patient of having new carious lesion in future or having the existing lesion progress. So some example are high streptococcus mutans and lactobacilli counts, visible plaque, and inadequate exposure of fluoride, and frequent snacking, deep pit and fissure, and also low socioeconomic status, drug use, and inadequate salivary flow, exposed roots, orthodontic appliance, and any physical or mental illness. So these all accounts for the risk factor for a dental caries in a specific individual. Here, though the key strand of the primary factors responsible for dental caries holds true, but we also know that there is a multifactorial etiology of the dental caries, which play a dynamic interplay between the demineralization and remineralization. For some caries protective factors, these are biological or therapeutic factors or measure that can collectively offset the challenge presented by a previously. That means the more severe the risk factor, the higher must be the protective factor to keep a patient in balance or to reverse the caries process. It's a dynamic process which takes place daily in all the individual. So some protective factors are lives or work, school located in a fluoridated community, fluoride toothpaste at least 2 times daily, mouth rinse, and professional fluoride therapy, and also chlorhexidine, xylitol gum, and also calcium and phosphate supplement paste, and adequate salivary flow. These all account for the protective factors in an individual. So, this is the caries balance model. There's always an interplay between the protective factors and the pathological factors, and they are numerable. And when the pathological factors overweigh the protective factors, there will be a caries progression. So, if the pathological factors overweigh, even in the presence of protective factors, there will be a caries progression. So these all emphasize the need of reliable caries risk assessment and identification of those at high risk for future caries. The management of dental caries can be complicated, especially for the patient with several pathological risk factors. So the successful management of dental caries relies upon the assessment of caries risk of an individual and treatment plan with a personalized therapy that is derived from the details recorded in the risk assessment with all the factors which we have seen now. So coming to the methods and models for CRA, generally now the most professional perform informal or intuitive caries risk assessment, that is by taking case history and patient examination and analyzing the risk factor or assuming the risk factors of a specific patient, such as single variables will be used like past caries experience and level of oral hygiene. So the risk assessment tools can aid in identifying the reliable predictors to allow dental practitioners, physicians, and other non-dental healthcare providers to more actively involved in identifying referring high-risk children so that disease progression can be stopped then and there. So now coming to the major CRA methods, it is classified into 2 major criteria, that is risk-based checklist and algorithm-based computer models. These algorithm-based computer models are computer software which can be used from the internet. First, coming to the reasoning-based checklist, it is based on the number of age-related background, such as biological, behavioral, and socio-economic status, with demonstrated association with caries activity. They are generally forms to be filled by the dentist or oral healthcare professionals, together with the parents and also the patients. And outcome is often recognized into the 2 to 5 risk groups, like high, low, moderate risk groups. Then coming to the algorithm-based computer models, they are computer-based models work in the same way, but the input factors are pre-weighed and it's already predetermined by the software, and these establish a caries risk profile and classify the future risk for the future disease. Some models are in a reasoning-based checklist. It is a caries risk assessment tool. And CAMBRA, that is caries management by risk assessment, and DCRAM, that is Dundee's caries risk assessment model. These are all comprehensive models which we have some specific forms for age groups, age related also. And coming to the computer based model, the most used and that is karyogram and NUS-CRA, that is National University of Singapore Caries Risk Assessment. It is for younger children and for previsor. These are the caries risk assessment tools. Here, by seeing all these caries risk assessment tool, we'll come to know one question will be always unanswered. This which caries risk assessment tool is validated and how to use. So the validity of these caries risk assessment tools are by the clinical practice and from the systemic reviews. It shows standard validity is also limited in the standard tools. So today we'll be dealing with the 6 caries risk assessment methods, that is caries questionnaire in combination with clinical observation, AAPD CRA form, karyogram model, and caries risk assessment and risk evaluation test, CAMBRA, and traffic light matrix. So overall in the caries risk assessment tool for an adult, the major criteria which we see are clinical evidence of previous disease, dietary habits, both the frequency and the consumption rate, and social history, especially socioeconomic status, fluoride, use of fluoride, plaque control, saliva, and medical history. So clinicians should be aware of an individual with both medical or physical disability for whom the consequence of dental caries could be detrimental to their general health as well. So these patients should receive an intensive preventive dental care. Coming to the first one, that is caries questionnaire in combination with clinical observation. In the title, it already shows that there is both a clinical caries questionnaire as well as the clinical observation. Featherstone et al. Evolved a consensus statement to assess individual risk assessment from a questionnaire that address issues such as maternal dental history, family dynamics, socioeconomic factors, oral hygiene measures, fluoride exposure, and frequency of sugar exposure. So all this was in a caries questionnaire. And after this, along with it, clinical observations were made, such as visual examination, tactile, and radiographic examination. Once the individual risk status was determined, they suggested using a minimal invasive caries management protocol that included appropriate preventive and therapeutic recommendations. The next one is American Academy of Pediatric Dentistry Caries Risk Assessment. It is a more sensitive and practical tool to assist dental practitioner, physician, and non-dental healthcare providers in assessing the levels of risk of caries development in all infants, children, as well as in adolescents. So the 2017 revised edition gives caries risk assessment forms formulated to be used by dentists for year 2 to 5 years old and more than 6-year-old children. So this risk assessment categories in this CRA form will be low, moderate, and high based on the preponderance of the factors for individual. So clinical judgment may justify use of one factor in determining the overall risk. So it utilizes the CRA as well as the care pathway model. These can be utilized in the limited resources and in the workforce issues. In all those things, these models can be utilized for the proper treatment regime. So this tool was developed by AAPD in 2006, and depending upon the children cat incorporates three factors such as biological, protective, and as well as clinical findings. So the care pathways used here for caries management in children was 0 to 2 and 3 to 5 years old were first introduced in 2011. Then care pathways for children further refined the decision concerning individualized treatment, and treatment threshold was based on the patient's risk levels, age, and compliance with preventive strategies. So these clinical pathways yield greater probability to success, fewer complications, and more efficient use of resources, less than the standardized treatment. So each patient had a specific preventive strategies. So this is the form showing the caries risk assessment for 0 to 5 years old. So three major factors which is used in AAPD form is risk factors, protective factors, and clinical findings. And three levels of risk are high, moderate, and low. In risk factors, social and biological, these are mother caregiver has active caries, and patient has a lifetime of poverty or low health literacy, and child has frequent exposure between the meal, sugar containing snacks or beverages per day, and also child using the bottle. So these all come in the high risk category. And child is a recent immigrant or has a special healthcare need, it comes in the moderate risk category. In the protective factors, it consists of child receiving fluoridated drinking water, is brushing with twice daily with the fluoridated toothpaste, and receive topical fluoride, and also is a regular dental care. So all these come under the low risk category. In clinical findings for children, we see child has non-cavitated white spot lesions or visible cavities or fillings and plaque on teeth. So all these come under the high risk category. By the practitioner, by circling to the risk category, we can come to know which risk the individual child is in. And according to it, preventive regimen can be given. For example, the risk category, in low risk category, diagnosing will involve recall every 6 to 12 months, and radiographs when necessary for 12 to 24 months. And for moderate risk, recall every 6 months, and radiographs when necessary for 6 to 12 months. And in high risk, recall every 3 months, radiograph every 6 months. In the interventions, we see fluoride, dietary counseling, and sealants. In fluoride, drink optimally fluoridated water and twice brushing. In moderate risk, we add upon with the fluoride supplements and professional topical treatment every 6 months. In high risk, there's a silver diamond fluoride on cavitated lesion. Here, they have recommended 38% of silver diamine fluoride, and also when giving this treatment, there should be always an informed consent, because there will be a staining of teeth. And dietary counseling is applied for all the risk groups. And sealants, the experts have specified sealants for all the three groups, and they have stressed upon the sealants for should be seen both on the individual aspect and also on the tooth aspect. But we should come to know why for low risk sealants have been placed, because the risk category might change, risk factors may increase, and the change in the tooth anatomy of the children. So in restorative care, surveillance in the low risk category, and active surveillance and frequent monitoring to decrease the caries environment and restore cavitated or enlarging caries lesion. In high risk category, it is active surveillance again and restore cavitated enlarging caries lesion. This is above 6 years. Here, the same factors involve risk factor, protective, and clinical findings. Here, both with poverty and low health literacy, and frequent exposure in midday, in between meals, sugar containing snacks, all comes under the high risk category. And similar thing, the recent immigrant and the special healthcare needs come under the moderate risk category. And protective factors remain the same in both the forms, which is a low risk category. And clinical findings, here it comes with the interproximal caries lesion and white spot lesions, and low salivary flow comes under the high risk category. Here plaque factor is not there. Instead of that, if a patient has a defective restoration or intraoral appliance, that comes under the moderate risk category. The management protocol is similar for both the forms. What all the contents we seen in the forms in the carriage management protocol is based on the results of clinical trials, systemic reviews, and expert panel recommendation. It gives a better understanding of recommendations for all the diagnostic as well, preventive and restorative treatments. And the radiographic diagnostic guidelines which were given like 12 months, 24 months, these are all based on the latest guidelines on the ADA recommendations, and systemic fluoride protocols are based on the CDC recommendations of using fluoride. Coming to the caries assessment and risk evaluation test. So here, till now we saw all the primary risk factors, protective factors, and clinical findings also. And with that, there are many studies which have already shown a strong statistical significant genetic component determining caries experience. So in this caries assessment and risk evaluation test, the major criteria is looked upon on the genetic component. So this may be especially important in developing societies that have a good dental coverage, adequate fluoride exposure, and where gross malnutrition and negligent oral hygiene are rare. So in all such conditions, even though having a dental caries, that means there is an increasing role in a child's gene, which may play a determining role in his or her caries susceptibility. So evaluating the child's genetic susceptibility to dental caries may play a vital role in assessing child's overall caries risk status. So this care model with the other standardized traditional model, we can easily say this is the future of dental caries risk assessment protocol. So this care model was given by the Division of Diagnostic Services of University of Southern California School of Dentistry and developed by a novel salivary test for genetic CRA, which is called as CARE test. So based on the high correlation they found between caries history and quantities for specific oligosaccharides in the whole saliva. So here they check for the salivary oligosaccharides. They are known to facilitate the bacterial attachment and colonization of the salivary pellicle, whereas other salivary sugar chain promotes agglutination and removal of free bacteria. Since the salivary oligosaccharide is 100% genetically determined, and identifying individual concentrations can help to determine the genetic risk of a child to develop caries. So it was also established that just like the blood group types, even the salivary oligosaccharide patterns remain quantitatively consistent over time and across the age groups. So this care test is probably the only CRA method that can potentially promote caries prevention at primary level itself by identifying the high risk caries in the children early and instituting a preemptive aggressive preventive regimen in them if they have high level of salivary oligosaccharides. So till now we saw the questionnaire with the clinical assessment one kind and AAPD CRA and care test. In the care test, we focus on the genetic component, that is salivary oligosaccharides. And coming to the fourth one, that is karyogram. It is a new way in which to illustrate the interaction between the caries related factors. It is a pictorial representation of interrelation of the various risk factors in an individual. This model was first presented by Bratthal as a graphical illustration of an individual risk of developing new caries lesion in the future. So this was given in 1997. It expresses the extent to which a different etiological factors of dental caries affect the caries risk for a particular individual. And original karyogram pie chart had a 3 different colored coding. So that first one was bacteria, which showed red color, and sugars, which were depicted in blue color, and host susceptibility in light blue color. Later, the purpose of demonstrating the caries risk graphically in terms of risk of developing new caries in the future and chance to avoid new caries in the near future. So then it was later modified into two more sectors, that is yellow sector and also the green sector. Here yellow sector shows the circumstances, that means the past caries experience or general health status, that is systemic diseases or that kind. And this green sector is called as the present percent chance to avoid cavities. So the size of the green sector is determined by the size of the other four sectors. By reducing or modifying the other four sectors, the size of the green sector can be increased. That means by reducing the other risk factors, the chance of preventing caries or chance to avoid caries can be increased. So for this pie chart, the factors and relevant information required to create a karyogram, we need caries experience, that is past caries experience, including filling, missed tooth due to caries. For that, information needed would be DMFT, DMFS, new caries experience in past 1 year, and also the related diseases, that is any systemic diseases, which include the information can be gathered by the medical history or the medications which they use. In the diet, it comes in the two kind, that is contents and frequency. In contents, it is estimation of the karyogenicity of the food, in particularly the sugar content. In that, we can see their diet history or the lactobacillus test count. In frequency, by the number of meals and snacks per day, the mean for normal days. And this can be assessed using a questionnaire results. We all know 24-hour recall diet chart, and even for 3 days diet chart. Other factors include the plaque amount, estimation of the hygiene, oral hygiene. This can be assessed by the plaque index and Newton streptococcus score. This estimation can be done by the Newton's test or other laboratory tests given comparable results. And fluoride program, estimation to what extent the fluoride program is available in the oral cavity. That is information can be gathered by the fluoride exposure by interviewing the patient, what kind of the toothpaste they use, and whether they are in the fluoridated water area, and whether they have taken professional fluoride treatment in the past years. And also the other component is saliva secretion. So this is the major component. Estimation the amount of saliva, for example, used in paraffin stimulated secretion, and expressing results as a milliliter saliva per minute. This can be done by the stimulated saliva test or secretion rate. Here, these factors are scored according to the 0 to 3. 0 is most favorable and 3 is unfavorable. It is a predetermined scale which is given in the karyogram model. So some factors have 0 to 2 and some factors have 0 to 3 scores. So how is a karyogram created? So the patient is examined and data collected for the various relevant factors which we have seen before, and the various factors or variable are given a score according to the predetermined scale and entered into the computer program. That according to its inbuilt formula, the program presents a pie with the 4 sectors taking its share. And showing that is dark blue sector, that is diet, which contain diet contents and frequency. The red sector, which shows the bacteria, that is amount of plaque and streptococcus mutans. And light blue sectors shows the susceptibility, that is fluoride program or salivary secretion, salivary buffer capacity, salivary fluoride. All this comes under the light blue sector, that is called as susceptibility. And yellow sector, we know that is a circumstances. It shows the caries experience or and related factors. And after all these four factors have been placed, then the green sectors shows the chance of avoiding caries. So we should know whether this karyogram is a risk model or a prediction model. Actually, the karyogram is both. It acts as a prediction model, that it predicts who is at risk and what factor is at risk. And it's also a risk model identifying multifactorial risk assessment, planning of interventions, and these risk factors are dominating factors, but past caries experience is also included. So the reason is that if risk factors are reduced, it can be easily reflected in the karyogram model. So here in all other forms which we saw before, in all other CRA tools we saw before, we had a socioeconomic status, socio factors. But why that factor is not included in karyogram? Because it often explains the reason of factors such as neglected oral hygiene or increased sucrose consumption. So these primary factors are already represented in karyogram. So social factors have been not used here. Then we should know why to use karyogram model. So this model is affordable, user friendly, and easy to understand by anyone. It can be a tool for motivating patient, and model can also serve for support of clinical decision making when selecting preventive strategies for a patient. And also it can be used as educating the patient, as it's a pictorial representation. It is easy to understand by the patient which risk factor has a major role in disease causation and the progress of the disease. So how to get hold of this karyogram? So there are several language versions that can be downloaded from the internet page, and also there is an app in the iOS and also in the Android, which can be downloaded in our mobile phones. So they have the specific factors which we have already seen. So accordingly, we should do the tests in saliva secretion, buffer capacity, and the score should be given. And the pie chart represents all the 5 sectors. So these can be utilized in the all clinics and even in the patient education and motivation as well. Peterson G. et al. In 2003 gave the opinion that karyogram predicted caries increment more accurately than any single factor model. And Miravet AR et al. In 2007 said that past caries experience, mutants count, fluoridation program, and buffer capacity of saliva are the factors included in karyogram that show significant correlation with caries risk determination by the program. And other factors that are that karyogram does not include, such as DMFT, DMFS, and plaque index, shows a high correlation with the risk. Now coming to the caries management by risk assessment, this is an evidence-based approach focused on the determining many factors causing the expression of disease and take a corrective action. Here there is risk assessment and also the risk caries management as well. This philosophy was introduced nearly a decade ago when an unofficial group called Western Canberra Coalition was formed based on the western region of USA. So this is an evidence-based approach for preventing and managing cavities at early stage. This was developed to promote clinical management philosophy in which caries decision process is managed following a medical model. So it evaluates the etiological factors and similarly as a protective factor, and it established the risk of future disease. And development of patient-centered evidence-based caries management plan is also given by Canberra. So this is the first step in caries management risk. First, we should determine the caries risk. It occurs in the 2 phases. That is, determine specific all 3 factors, that is disease indicators, risk factors, and protective factors what a patient has, and determine the level of risk that some of these factors indicate. So this is the caries imbalance model. It's a dynamic and delicate model. It has a 3 factors, that is disease indicator, risk factor, and protective factors, which we know there is always a balance between the pathological factors and the protective factors. So we can use a mnemonics, that is disease indicator VREC, that is white spot, restoration, enamel lesion, and cavities, and risk factor, that is bad bacteria, absence of saliva, D for dietary habits, and for protective factor it is safe, that is S for salivary and saliva and sealants, antibacterial usage, fluoride regime, and effective diet. So it's a balance between the remineralization process, which we have already talked about. And when the protective factors overweigh the pathological factors, there will be no caries. And when pathological factors overweigh, there will be a caries progression, even though in the presence of any protective factors. So this is the form first form, which is given for below 6 years of age. Here the caries risk component is assessed by scoring. Like for column 1, it's -1, +2, and +3 scores are given. The major criteria in the camera are biological or environmental risk factors, protective factors, and biological risk factors and disease indicators as well, similar to the AAPD. But here the frequent snacking, using bottle, and siblings have a decay history or caries history, and families low socioeconomic status, medication, all these come under the column 2, which we should score for +2. And in the protective factors, the fluoride treatment, fluoride regime followed, daily fluoridated water, and use of fluoridated toothpaste, all this comes under the score -1, which means low risk patient. And then the biological risk factor, that is heavy plaque on the tooth, that comes under the +2. So all these risk factors come under the +2 score. While these disease indicators, white spot lesions or recent restorations, also comes under the score column 3, that is we should score +3. Then the sum of the scores gives the whether the patient is in low, moderate, high, or very high sector. So these are the score. When the after the completing this form and adding up all the scores, a patient with low score of -4 to -1 comes in the category of low risk category, and with the score of 0 to +3 comes under the moderate risk category, +4 to +13 comes under the high risk category, and very high will be +14 to +18. So, in simple terms, the dental caregiver has responsibility of making caries risk assessment and then deciding the caries management plan. And for the patient, that leads to the risk assessment and also the personalized assessment for the needs of the individual patient. Here we saw low risk patient. In low risk, the scores which we get if there are protective factors and there are very few risk factor or no disease factor. Those come under the low risk. If there are no disease indicators and risk factors and protective factors, it appears to be balanced. So such comes under the moderate risk. And if there is any doubt, so move towards the moderate to high classification. If in high risk patient, it is that it's already a disease indicators has been present, and if there is no disease indicator also, if the risk factors are more, those patients come under the high risk category. Very high risk category, presence of this risk disease indicators, and also they should be given more aggressive and caries management plan. Now coming to the second part, first we did the caries risk assessment. Then the part 2 will be the caries management. That will be dietary counseling and the nursing bottle used continually. That should be recorded. Record details should be provided, and fluoride toothpaste use. We should note the amount of frequency. Note the frequency and amount should be used at each visit, and record all the recommended therapy, that is varnish, use of silver diamine fluoride for appropriate cases, and recording of the medication, participation in any school lunch programs or head start programs, all this, and child has development problems, all this should be assessed, and such patient counseling should be given, and even inadequate saliva flow and recent medications all should be taken care of. After assessing this, a particular preventive regime should be given to a patient. Here, at each visit, 2 goals should be given to the specific patient, and it should be always given in the writing. So this is the second form for above 6 years. Here we see the specific protective factors similar to the other forms, and we score -1 in all the category. And here the biological and environmental risk factor, we see frequent snacking, hyposalivatory medication, and recreational drug use. And here in other risk factors in biological are heavy plaque on tooth, reduced salivary function, deep patent fissure, and tooth exposed tooth root, orthodontic appliance, all we give +2 score. And in the presence of any disease indicators, that is any cavitated lesions, white spot lesions, and new non-cavitated lesion only which is seen radiographically, and presence of restoration in past 3 years. So all this will be given score +3. Similarly, we'll add all the scores, and according to the scoring criteria, we specify whether an individual is at low, moderate, high, or extreme risk. Here the scores are different from the form given clearly. So this here low is -8 to -2. If the scores are -1 to +2, he is in a moderate risk. And if the scores are +3 to +17, he is at high risk. And if a patient is +18 to +30 score, he is at very high risk. So, similarly here in low risk, there are no disease indicators or very few or no risk factors, but protective factors prevail. Then he is at the low risk. Moderate risk, if the patient is not obviously at high or extreme risk, but there is a doubt about the low risk, then the patient should be allocated to the moderate risk. For example, if a patient has undergone a root canal root canal treated tooth, and he is doing fine, and there is no history of clinical active lesions, but there are some exposed roots, and he is brushing once daily. So these terms comes under the moderate risk category. And in high and extreme risk, one or more disease indicators most likely signals the high risk. And if there is an hyposalivation, he is at the extreme risk. Here, the risk factor will definitely overweigh the protective factors. So here, similarly to the other forms, in above 6 years and adults, we use caries management similarly with the diet counseling, with the frequency of amount of fermentable carbohydrates he uses, and oral hygiene and fluoride exposure, and record all the recommended therapies such as fluoride toothpaste, varnish, chlorhexidine, and usage by the patient, and record medication at each visit, and even recording the participation in any specific programs, and also if there are any developmental problems, inadequate salivary flow, all this should be recorded at each visit, and should know what's the progress in a specific individual, and should plan accordingly at each visit the preventive therapy, or if there are any restorative therapy for arresting of the caries active lesion. So here, for low risk patient, consideration must be given for remineralization. That means the arrest of incipient caries or pit and fissure sealant application, which provide ultimate conservation of the tooth. And for preservation of tooth structure and slow caries progression, minimal intervention program can be given for the high risk patient. Here, generally high risk patient, we focus on the restorative care as well as the preventive regimen. And here, since camera approach is based on research, clinical expertise, and patient preference, and individual treatment implemented of this protocol will provide an ultra conservative tooth preservation that gives a good patient care, and also it motivates the patient, and it increases the dental care visits to the dentist. The last one will be the traffic light matrix. As the name suggests, traffic light. So it uses a color code such as red, green, and orange to convey specific threshold values of data obtained in the analysis. This is commonly used CRA tool in Australia. So the objective is to alert the clinician regarding the current risk status. Here, this model keep the visual representation simple and easily communicable to the patient. The one model which we saw visual representation was the karyogram. The other one, this one is also visual representation. Here we have 5 different categories which has 19 criteria. So in saliva, the first category will be saliva, which has 6 criteria. Plaque, which has 3 criteria, diet, which has 2 criteria, fluoride exposure, that is 3 criteria, modifying factors, which has 5 criteria. So this CRA tool is a algorithm based, that is software determined CRA tool. So here we saw in saliva, we see resting saliva, we check for hydration, viscosity, pH, and for stimulated saliva, we use quantity or rate, pH, buffering capacity. In plaque, we see the maturity and bacteria, that is mutants count, and in diet, we see number of sugar, acid exposure in between meals or day. And also fluoride exposure through water, paste, or professional treatment. So, and other modifying factors such as drugs which you reduce the salivary flow, RPDs, and active caries and poor compliance. So the specific threshold values for the data obtained in the analysis are aforementioned factors are conveyed in a traffic light signals. That is, red means it's a self-explanatory, high risk, low is moderate, and green, yellow is moderate, and green is low. This color code models keeps the visual representation simple and communicable to the patient as well. For example, if the sugar exposure in between meals is more than 2 and acid exposure in between meals is more than 3, it refers to be as a red, that is high risk patient. If it is more than 1 or more than 2, this represent a low risk patient. And if there is no sugar exposure in between meals and acid exposure is just 1 in between meals, then it refers to be as a low risk group. So we saw the overall six kind of CRA tool, which is generally practiced, and these what all the tests which we check in all these tools will be the bacterial challenge. That means determination of mutants, streptococcus as an indicator of relative risk, and in that we see for lactobacillus count, which is indicator of sugar content in the diet, and in remineralizing potential, that is the protective factors potential, we see the salivary flow rate, buffering capacity as an indicator of potential biological repair, and also host susceptibility. That means the past caries experience also we see in the host susceptibility. So we should know what is the accuracy of the caries risk assessment tool which we follow. So the precision and accuracy is expressed commonly as a sum of 3 levels, that is good, limited, and poor. Here, past prevalence, caries prevalence activations and multivariate model which we saw, that is camera and karyogram, these give a good accuracy. But while the dietary habits, sugar frequency, socioeconomic status, all this give a limited accuracy for the CRA tool, and poor accuracy will be given by the only the single indicators such as oral hygiene level, fluoride, salivary function, bacterial levels, and mutant streptococcus score. So, as the level of evidence concerning the patient perception and benefits of CRA is still graded as low, because there is a need for more research on the value of caries risk assessment for various stakeholders, and including patient and dental practitioners. So the clinical application of CRA, it is instituted by the data from practice-based research indicate that 30 to 40% of general dentistry dentists do not carry out any formal caries risk assessment for their child or for their adult patient. So adoption of the camera model in routine practice can increase the preventive measures and reduce the caries increment by up to 20% in the adults. The patient can be classified as a lower risk level after being provided with tailored risk-based preventive measure. Here we all focus, we know that there is a levels of prevention, primary, secondary, tertiary. But here by the use of CRA tool, we are majorly focusing on the primordial prevention, preventing the risk factors to come into the patient. So, just by motivating the patient, we can't infuse or change the behavior, or we can't have adherence to the preventive regime by the patient. So, we need specific model, that is COMB system illustrates that motivation alone does not necessarily induce behavior change after caries risk assessment. So, we need capability and opportunity which enhance the facilitate changes to be more favorable overall health. So here, capabilities, opportunity with motivation together within a patient cope with alter their caries risk behaviors and emotional maturity. And overall, this will increase the adherence of the patient with the preventive regimen and the periodic recalls and programs. Coming to the uses of caries risk assessment, we evaluate the degree of patient's risk for developing caries and also to determine the intensity of treatment. And it helps to identify main etiological agents and determine what type of treatment to be given for the particular patient. And it determine also additional diagnostic procedure if required, like salivary flow rate analysis, diet analysis, and improve reliability of the prognosis of planned treatment. We can easily assess by following this preventive protocol whether there will be a caries progression or caries stabilization. So assess the efficacy of the proposed management and preventive treatment plan. At all recall visits, we can assess the patient's condition. Coming to the conclusion, the management of caries based on individual risk has been recognized as a first step forward to achieve better outcomes of overall health. And using the risk assessment form assists clinical decision making, and it increases patient understanding and adherence to the preventive care regime, and also allow clinician to assess the impact of their preventive and management strategies as well. And using a system that combines all the information gathered during the risk assessment to empower the patient with the knowledge of factors relevant to them personally can be very helpful and lead them to improve their health choices, especially when reinforced periodically. So, summary, what all we saw was what are the caries risk factor, disease indicator, and protective factors in the dental caries causation, and why we need CRA and what it contributes to. And we saw some specific models for CRA and its classification, reasoning based and algorithm based. And in that, the major standard traditional followed are caries questionnaire in combination with the clinical observation, and APD's caries risk assessment form, which has two forms, and karyogram model, caries assessment and risk evaluation test, which focus on the genetic component, and then caries management by risk assessment, which has two forms as well, below 5 years, below 6 years and above 6 years and adults. And with that, the caries management also we saw, and traffic light matrix CRA. Then we saw about the accuracy of caries risk assessment and clinical application and its uses. So these are my references. The probable caries question asked are in the last PG exam in RGHS. They asked about the discuss caries risk assessment as a tool in dental public health. Not only here in the UGs, it focus on the karyogram, caries risk assessment techniques are all asked in the 5 marks questions. Thank you.
Okay. So that was Dr. Karishma there. I think very, very comprehensive and an excellent session, I believe. Especially a topic like this, caries risk assessment, discussing the rationale and the various tools, of course, is not an easy task. And I must say, Karishma has done a very fantastic job in that. Now, quickly, I think if I could open up the house for discussion, I request the participants to please switch on their videos. I think let's hear from Dr. Padma Bhatt, ma'am. Yes, ma'am. Today you heard Karishma present on a different podium. Your thoughts on the session. Again, also request the other teachers, Dr. Soumya, ma'am, to address all of us. Okay. Now, when we look at the session overall, right, especially because there has been a paradigm shift in our understanding of the dynamic and the multifactorial nature of dental caries in the first place, and the resultant change which happens as the method of caries preventive and the treatment strategies, these make or necessitate the need for caries risk assessment to be an integral part in the caries management protocol for any patient for that matter. Now, caries risk assessment, fundamentally, like how Karishma mentioned through the various methods and the techniques here, it actually fosters the whole process of treatment, instead of just treating the outcome of the disease. When we talk about dental caries, it's not just about treating. So if you're looking at a more inclusive and a more sublime approach to the management of dental caries, caries risk assessment is definitely going to feature in that. Also, it allows you to give an understanding of the factors responsible for a disease, because there are certain specific patient oriented factors, and it helps you individualize the preventive procedures for all of them. And by means of individualizing, you're also able to select and determine the frequency of how much of preventive and how much of restorative treatment they need. And this is actually a very, very clinically important point for practitioners also when we look in that perspective. And of course, above everything else, it anticipates your caries progression, or how stabilized the lesion is when you look at it in that larger perspective. So I think if we can open up the house for some discussion here. Quickly, any PGs, UGs, please do raise your hands, or you can go ahead, you can unmute and ask questions to Dr. Karishma. She'll be more than happy to answer you. Okay. So like I mentioned, we shall be sharing the slides of today's presentation. You can always join our learning group. Just put the link in the chat box. So definitely there's a lot of content here, and very well updated and researched. And you can always look it up. And like I said, a special note for the postgraduates attending the session. This is quite a favorite among examiners, and it also features in your public health DPH and paper 4, which is recent advances. So that is one of the fundamental things. Okay, so I think we have Dr. Padma ma'am. Yes, ma'am, good evening. Yeah.
Yeah, good evening. That was a good presentation also from our student, a very favorite one, Dr. Karishma. And since she has covered most of the topics, most of the topic that was very essential, that will be useful also. So glad to know that Dr. Janji, you have been promoting this kind of an activity, which is very, very useful and helpful for the public health dentistry profession as well. So that is nice from the organizers team to rope in Dr. Karishma. And you're also most welcome, but it is very pleasurable to see her on the screen, I must say.
Thank you so much, ma'am. Means a lot.
Okay, thank you so much, ma'am. I think those are lovely words from the teacher herself to her student. Okay. Thank you, ma'am. Thank you. I think moving on, we also have Dr. Aruna ma'am here, of course, another senior faculty member. Yes, ma'am is there. And anybody would like to say anything? Otherwise, I'd like to request Dr. Soumya ma'am to just propose a vote of thanks for the session today before we can wrap up the session for the evening. Also, do let us know if you want any queries. I mean, please do write to us at publichealthdentistry101@gmail.com. You can always, we'll try to help you with a lot of study material, be it for undergraduate or for the postgraduate syllabus. So we will be focusing on topics subsequently every Wednesday, keeping the exams in mind, because we've gotten a lot of requests from students on specific topics. So we'll try to cover as much as possible, and then we shall definitely take this forward. Okay. So thank you so much, Dr. Karishma, for doing this, for taking our time for all of us. I'm sure all of us and the students who attended the session have immensely benefited from this voluminous presentation. Thank you so much for doing this and making it happen. And thank you to all the teachers who are all patiently sat through the session and given their inputs. So I think we couldn't have asked for more. Thank you so much, all the teachers. And then again, thank you so much, Karishma.
Thank you, sir. Thank you for the opportunity.
All right. Okay. So for people, in case if you missed some of the session, you can always find this session. It is already live streamed on YouTube, so you can go back and revise as well. And we'll also be sharing the slides in our student learning groups. And if there isn't more questions, I think we can wrap up for today. Thank you so much, everybody, for attending the session, and I hope you've found it really beneficial for you. And once again, thank you so much, Dr. Karishma, for the comprehensive session today. Thank you.
Thank you, sir.